I wanted to spend 5 minutes talking about electronic health records and another associated concept of health information exchange. The two are linked. I don't know if you've had a chance to read the article that was in the Forefront, the last issue of Forefront Austin, but we have been focusing, we being Central Health, have been focusing on the expansion of implementation of electronic health records into what we refer to as safety net providers in the community. Safety net providers are typically those that serve individuals that either don't have insurance or are what we call underinsured, meaning they might have coverage such as a state program like Medicaid or Medicare, but because of the way those programs pay, there tends to be difficulty with the actual number of providers that would be willing to see that patient and provide their care. So we have a lot of institutions in the community. Some are very traditional 501c3 based organizations that rely on reimbursement from the patients or maybe community philanthropy. And some, such as our system, we have a very large 20-center health care system that is funded through public funding. But these systems basically are focused on providing care to those that don't have access otherwise because they don't have funds. Electronic health records implementing electronic health records in those safety net providers helps us link their care across a very disjointed continuum. If you think about how you access health care, let's say you have Blue Cross or you have United Health or some very standard commercial insurer. You know pretty much anything you need is going to be covered, maybe subject to some haggling them about how much and which providers are in your network and such. But if you are uninsured or underinsured, you typically seek care in the place that you can get it. That's often the emergency room. It might be a safety net provider one time because they could get you in. It might be another safety net provider another time. That care's often the information about that care is not linked, it's not transmitted anyway back and forth. So back to the concept of creating a health information exchange. A health information exchange takes information from electronic health records, puts it into a single repository, a single record for patient, allows information to flow both in and out. So if I'm a doctor, which I'm not, treating a patient, if Terry's in front of me today, I can check that record to see if she was in the emergency room within the last period of time that I want to search. Or if she tells me she was in the emergency room, I can go in and see that visit occurred, what her diagnosis was, possibly what laboratory, what labs were drawn, what ancillary testing occurred, and that gives me as a doctor more information about what's happening with Terry and her care. This is often very important for patients that we're serving. We deal with a lot of individuals who English might be a second language, and we're not just talking Spanish, we're talking multinational, multi-international. And oftentimes, I'm sure if you've ever had an emergency room visit, when you go in there, you're not sure you absorb everything they told you. So your ability to bring that back to the doctor that you're seeing after for follow-up is somewhat limited. So these health information exchange, by having electronic health records that can contribute data, help us both deliver care, more efficient care at the individual patient level by assisting the provider, but it also helps us look across an entire community and what is happening to patients and all the care that's provided. It gives us trends in disease, it gives us trends in what we call utilization. How many ER visits are taking place, how many primary care visits are taking place, how many times does someone go to the ER for a treatment of asthma, how many times were they hospitalized because of asthma. We can then go in, identify those patients and try to intervene, get them into a medical home, and actually reduce that rate of asthma occurrence, get them into a more chronic maintenance program, reduce their actual hospitalization. So we're focusing on care delivery, exchange of information, improvement in health by having access to the information. The other thing I'd add to that great and lofty goal is it costs a lot of money and it's not all figured out because there are multiple vendors with multiple platforms, and a lot of what we do is a lot of what I call customized programming to make electronic health records interface with health information exchanges in the ways that are most efficient. Another thing I'd add, I think I'm probably up to my 5 minutes, if you think about this at a local level, a state level, and then a federal level, some of you may have understood through all the discussion about, with the, let's see, it was the ARRA, American Recovery and Relief Act, and then subsequently through the health reform, there's been very specific focus put on implementing electronic records, and providers need to have electronic health records in order to meet what they call meaningful use standards. So in order to get paid, you're going to have to be able to produce certain information and show outcomes. So at the local level, you have electronic health records. Think about your doctor, your hospital, wherever you're going is going to have an electronic health record. There are requirements that information be able to be fed into what we call the federal, we call the health information highway. That information is either going to have to be fed up through state exchanges that then feed into federal exchanges, or go directly from local up to federal. So it's the multiple levels. So getting there and getting to that ability to do that in a compliant and efficient way, there's still a ways to go. And as I mentioned earlier, there's a lot of money involved in putting these systems in and having them work as expected to actually be able to experience the value that's anticipated by it. This is happening in our community at what we call the safety net level, but it's going to become more and more a part of your life too, in terms of your own provider, where you seek care, your own doctors, because where everyone's sort of being nudged towards this requirement to have electronic health record capability. It will also have in the future some capability for patients to, I don't necessarily want to say feed into that record, but to be able to access that record and possibly update that record with salient information. Those are things envisioned in the future, so it's not just a single direction, but it's actually bi-directional. That's referred to as a patient portal, the ability for you as a patient to have some access to that information. It's going to be, I think, very enlightening over the next, say, 5 to 10 years where this all ends up. There's a great vision for it now. I'm not sure how it's all going to materialize. I do know what we're doing locally. We have a very large vision for it. It's working in many respects. We know what we have to do to improve it, but we're also having to work very hard on getting the investments to make those improvements and make it sustainable over time. So that's my probably 7 minutes. But
well, would you mind, sorry. That's okay. Would you mind talking a little bit? I had the privilege of interviewing one of the doctors who is, on a routine basis, is using electronic health records. And one of the things we talked about at the start of the discussion was technologies on their own are great. They're fun little gadgets and gizmos and all kinds of fun stuff. But can you talk a little bit about how it's maybe changing the way a doctor is going about his or her day or working with patients?
Absolutely, that's probably the biggest area of controversy too, because when you think about a doctor who has a practice, and if you think about that practice basically being driven by paper, you come in, you sign in, you fill out, how many of those darn forms do you fill out? Every time you go in, you're filling out another demographic form, which they're turning around and feeding into their billing system, and then spitting it out to you the next time you see if it's still correct. All that paper flow becomes automated with electronic health record, and what happens is it affects the flow of the work throughout the day. So the biggest resistance you'll see from physicians is, does the record support the flow? It usually requires a change in the flow. The change is actually efficient over time, but we all know that we're not real good about making change. The other part of it is electronic health records have, I would say they've significantly evolved over the last decade, because when they first came out, you essentially had what I call good intention programmers trying to basically take data and put it in database form and then be able to run a program that allows a doctor to collect that and feed it into a database. That's become a much more sophisticated practice. The software companies have had to work with clinicians to understand how they really practice medicine and what they need out of the system that supports them practicing medicine, not just adding another 5 minutes of record keeping into their day. So if you talk to a physician who started a practice without paper, just straight electronic health records, they will feel much more, maybe have a more positive experience because they don't know anything different, and they can use, up front they can decide how they want to use that system and program it and utilize it appropriately. The conversion from paper to electronic system is difficult, and it's also, going back to my other point, it's expensive, so you might see, you see it being adopted in larger practices, but not the smaller. If you go to does anybody go to a single practitioner anymore? Does one of those exist? You have one.
Yeah. My children's pediatrician child. And he's never gonna use electronic health records.
They'll retire before they do that.
Yes.
Actually, that's a really good point about generational differences. You really do have some, and they're very straightforward. It's like, I'll just retire
in 5 years. I don't need to learn that.
I don't need to learn that. It's not going to hit me as a requirement. Yeah. But the younger physicians, and especially now, those that are being trained, many of the training, the education centers have electronic health records as part of their training experience. So they're kind of interesting because they come out and they go, well, what do you have in your practice? I don't know if I want to work with you. What have you got? I'm used to working electronic records. So you've got this vast generational difference from those that we're not even sure they use their own email at home to those that say, I don't know how to practice other than on an electronic system. So in terms of it implementing and trying to move what I call move to better efficiency through the electronic health record system, there's a lot of art to it because there are a lot of systems out there, and depending on how they're implemented and how they're utilized, a practice can feel like they've become more efficient and the doctor's helped in delivering care, or they'll feel like you just added more administrative burden. I've seen situations where there have been conversions of what I call paper systems to electronic systems, and what happens is they never get off the paper, and then they run parallel systems, and that's not more efficient. Now they're doing two things. They're collecting it on paper, then someone's sitting there at the end of the day and putting it into the electronic record, and that just defeats the whole purpose. But that just points out the difficulty in people adapting to change.